All right. I'm back with Dr. Katie Dolbec. We're going to talk about the collapsed runner, some legit sports medicine stuff right here. Um, what do we need to think about?
Yeah, great. So I think what's so fun about working at local endurance athletic events is that a lot of the medicine we see there is very different than what we see day to day in our emergency departments. So when someone collapses at the finish line of a race, their potential pathology, some of it's similar to what we would see in the ED, but actually a lot of it is different. And you have to have some other real emergencies on your mind to make sure that you're appropriately treating those athletes. I will start by saying that something called exercise associated collapse is very common following, especially running races, Nordic ski races, immediately after crossing the finish line. And so, what happens is that over the course of 5K, 10K, marathon, whatever the distance is, the athlete's body has gotten used to receiving venous return from flexion of the leg muscles, like the entire lower extremity musculature essentially is providing contractions that are bringing blood back as part of your venous return. And so, a lot of the other mechanisms by which we get venous return are sort of they are like okay, and you're a little bit venodilated, right? So you're vasodilated as you're trying to dissipate heat, and so the runner or the Nordic skier or whoever it is crosses the finish line. And what do? They stop and they stand there and they lose all of that venous return from the legs. And suddenly they have no preload and they get really lightheaded and dizzy and they often fall to the ground.
Hmm.
Most don't lose consciousness, but they get pretty woozy and they lay there for 30 seconds or a minute. You put their feet up and they walk away and they're fine. So I think it's still important to make sure they're all breathing, that they have a pulse as they cross the finish line. Maybe you're sitting there as a spectator, maybe you're sitting there in the medical tent right near the finish line, and you see a bunch of people going down, and you do have to look at them all to make sure that they are still breathing and that they're moving a little bit. But ultimately, most of those folks are going to hop up and be fine, which is again very different. And if someone collapses in the emergency department,
Yeah.
all hands on deck. And I think it's really good to have a couple of people kind of positioned at the finish line of a race to expect this. And actually, one of the things to tell anyone who's ushering athletes from the finish line is to have them keep moving. So they don't really want to, but even walking will stave this off. They'll feel crummy for a few seconds, but then they'll come, back to, and everything will be, they'll re-equilibrate essentially, and everything will be okay. So if you can avoid the stop and grab your legs and bend over, uh,
Hmm. Right.
move, you'll really prevent a lot of these from happening. But these typically happen after the finish line. Now, can you still have bad things happen after the finish line? Absolutely. But most of the things we're going to talk about in a minute that cause collapsed runners during the race are a bit more ominous.
Okay. But if you collapse
So,
during the
yeah,
race, what are we thinking about? And when you say collapse, are we talking about syncope or just falling to the ground?
either any of those. So
Okay.
syncope, falling to the ground, altered mental status, inability to sort of continue to self-propel forward in a meaningful way, I would say is
Okay.
I'd encompass into this collapsed athlete bucket.
Okay.
And mostly I'm talking about running in this. I think there is definitely the possibility you could run into this with other endurance sports, but I think running is the one we encounter the most. And I think even if you're seeing these athletes on the sideline, I think this is important. But you may be working at your local ED when the local 10K is happening, road race, and you may start seeing athletes from that event. And so knowing these tips and tricks are going to be really important for you treating patients in the emergency department too.
Okay.
Um, so what is the first thing that we do when a patient comes in sweaty, they just exerted themselves, they're a little woozy, whiffy, maybe their blood pressure's a little low? What's the first thing we reach for as emergency docs?
Normal saline,
Normal
lactated
saline.
I
Yes, we're going
fluid.
to hang fluids, right? We're going to start running fluids wide open. We're going to rehydrate this person. We think that is the problem. So I would argue do not do that. Do not start fluids on a patient until you know their sodium. Um, Hyponatremia, exercise-associated hyponatremia is a very real entity. And by giving them normal saline, you may actually continue to drive their sodium lower and you may actually kill that patient. So not everyone needs IV fluids. Actually, a lot of these patients will have overdrank free water and will have consumed enough water to make their blood hyponatremic, to make them hypotonic. So you should have a sodium before you start those fluids in most like ultra endurance events. And I think maybe a 5K, maybe not so much, but in a certainly 10K marathon, be thinking about over drinking and hyponatremia as a possible etiology, right? There's a bunch of things that are causing you to lose sodium. So sweat is the big one. And then your ADH is pumping and you're holding on to free water. And you might have a little bit of so the vasopressin, and then you've got a little bit of BNP circulating as your heart has been stretching, and that causes you to hold on to some fluids as well. And suddenly you're not losing as much free water as you're putting in. And so I would argue not to start IV fluids until you have a sodium back on most of these patients, and they're going to do fine. It's not dehydration that's going to kill them, but your fluids can. So always get that sodium. A lot of endurance races will have an I-stat available, so that's awesome. You start the IV, you grab the I-stat, 3 minutes later you have a sodium to work off of, and you can then decide whether or not to give fluids. Because
now,
the
if
treatment
they are hyponatremic, is there a risk? I'm wondering, like, those people will probably start to correct pretty rapidly.
Yeah, most of them
is that
will.
a risk, or is that okay in those situations?
No, that's actually great. So if they start to auto-correct and they're starting to diurese, that's great. So that's if they're mildly hyponatremic, their levels aren't terrible, their mental status is pretty good, then you can absolutely let them auto-diurese. Now, if they're seizing or they're really altered, you should probably be reaching for the hypertonic saline and giving that.
Okay.
Yeah. So that would be a case where I would not reach necessarily first for the benzos. I would reach first for the hypertonic saline. So, maybe they have an underlying seizure disorder, but, you'd hope they have a bracelet or a dog tag or something. If we don't know that this patient has an underlying seizure disorder and you're at mile 18 or 19 of a marathon on a hot day, I would reach for normal or hypertonic saline before benzos, because that's more likely to be your etiology.
Right. And if you don't have hypertonic saline, I love to use sodium bicarb that we often do have.
Would work. That would work. Yep. That's got a very high concentration of sodium as well. So that's great.
Cool. Okay.
Another one to think about is exercise associated hyperthermia or heat stroke. So you get that altered runner. It doesn't even have to be that hot of a day. If it's humid and there's any reason that maybe it's really sunny, there's any reason that athlete is having a hard time dissipating heat, they can get really hyperthermic and can actually develop heat stroke. So they're altered, and you're like, oh gosh, I don't know what this is. Maybe they're having a stroke, which it could be. Maybe there's something else going on, but don't forget to check a temperature, and that temperature should be a rectal temperature. I know that sounds kind of crazy, but every endurance race should be equipped with rectal thermometers, and EMS crews locally should be well versed in that as well. And if you're seeing that patient arrive in the ED, your first thought should be a rectal temp. So the diagnosis of heat stroke is made by a combination of a temperature over 40 degrees rectally, as well as altered mental status. And if that's what you encounter, let's say your patient's temperature is 42, and they're confused and they just completed this race, you should dunk them in ice water if you can. If you can't do that, you should be going next for evaporative cooling. So misting, and then fans, anything you can do to try to immerse this patient. I think ice bags in the groin and axilla is fine if that's all you have, but you should be getting them wet and trying to evaporate. Anything you can do to rapidly cool them is really important. Once they hit about 40 degrees, hopefully their mental status is improving. But regardless, you should probably start eliminating the really active cooling. And at that point, letting them kind of come down those last few degrees on their own, because there is a risk for an after drop and you sort of get them too cold and then you're fighting to get them normothermic again. But you should really be thinking about rapidly cooling these folks. They're brain is frying in front of you. And so recognizing exertional heat stroke as a possibility and treating it if you're identifying it is really important.
Cool. Okay, so during the race, we're thinking about hyponatremia, hyperthermia as two main
Mhm.
causes.
Exactly. And then don't forget about the normal stuff. So we sort of alluded to this earlier, but could someone be hypoglycemic? Absolutely. Maybe they are actually having a cardiac arrest. Maybe it's not exercise associated collapse at all, but rather a cardiac arrest. Make sure you're taking a pulse and recognizing that. Maybe they actually are anaphylactic and they got stung by a bee out on the race course, or maybe they decided to eat a peanut butter sandwich and this was the day that their body decided they were now allergic to peanuts or something like that.
Right.
So all the normal stuff for sure. And could it be hypovolemia at the end of the day? Sure. But I think two things to think about: the patient rolling into your ED who's just been part of an endurance athletic competition, especially running. Make sure to check a sodium before you start fluids and check a rectal temp, and aggressively cool if it's over 40 and they're altered.
Now, what about I'm just thinking rhabdo because it's like every time I
Mm,
think of runners, I always think of rhabdo. Is that something that we should be thinking about in the acute setting for for a runner? I mean, I don't see why it would
yeah.
cause collapse, I guess, but
It shouldn't cause collapse. I would I would caution against a bunch of routine labs actually. So we know that their CK is going to be elevated if they just did an ultra endurance race, and we're not really going to know what to do with it. You could check a urine if they're not having myoglobinuria or their urine looks grossly sort of clear yellow, then it's probably fine to not go that pathway. If they can't walk, then yeah, maybe they do have rhabdo and I would worry about it. But if they can still ambulate, they're sore, but they can ambulate and their urine doesn't look grossly, brown or red, I think you can sort of ignore that. And checking a CK is only going to get you a little bit into a spiral of rechecking and rechecking again and trying to capture a peak. And ultimately they're all going to be a little elevated. So I would actually not check that. Another one, troponin. They're all going to be elevated. You don't
scary to
necessarily
think
want to
about.
know that. Yeah. Don't ask the question if you don't want to know. So troponin, unless they're having active chest pain or they had a cardiac arrest or you see a STEMI on EKG, I would not go checking troponins on these folks. They're going to be elevated.
Guessing lactates are going to be super high too.
Lactate's going to be really high. Another one you don't necessarily want to check. Um, some others that you might not think about: LFTs, AST, ALT. Those are going to be elevated. Those are found in myocytes as well. So they're going to have a little bit of spilling of AST and ALT into the bloodstream as well. And so you're going to have these transaminases that you're not going to know what to do with. And
Oh,
if they're
interesting.
having some vomiting or some nausea, you're going to think, oh my gosh, is this acute hepatitis? No, this is unfortunately just a lab abnormality that's associated with this endurance activity. Um,
Very
yeah.
interesting.
Yeah,
Oh,
they may
that's
have a little
cool.
anemia. We can not uncommon after an endurance event to lose little bits of blood in the capillaries of the feet, little bit in the GI system. Not uncommon to have a little bit of GI bleed. Actually, we're not totally sure why. There's probably like a little bit of an ischemic colitis that goes on. Um, but yeah, not uncommon to have like hemoccult positive stool.
This is making me never want to run again.
Running's the best. Great exercise. Perhaps in moderation.
Yeah,
Safe moderation.
just run down the stairs and that's it.
That's it. No, marathons are fun, and I encourage people to work at their local races. These are really fun opportunities to give back to the community and be involved in a really high energy event, and just recognize that the pathology you see just may be a little different than your day to day ED shift, which is also keeps things really fun and exciting.
Sweet.